a topic that is at the heart of resilient supply chains, essentially forecasting and supply planning, and a specific focus on how artificial intelligence can transform forecasting and supply planning. As everyone who has done a forecast before knows, accurate forecasts and timely decisions have always been critical. But nowadays, and we all know what the pressures are like in terms of shifting demand, extremely limited resources, and unexpected disruptions. These happen all the time. And so I think forecasting and supply planning can play a really important role in helping us with speed and precision. And of course, artificial intelligence, we believe, can really enhance the way we do forecasting and supply planning with the view of efficiency and speed. So over the last few years, we have been designing and piloting a suite of these AI-enabled forecasting supply planning tools in very close partnerships with the Ministry of Health in Kenya and in Tanzania. And in Kenya, we've also worked at subnational levels with county governments in 5 counties. And our goal has been to shorten planning cycles from weeks to days, really to support data-driven prioritization. At InSupply, we spend a lot of time thinking about how we can use data better and data use. And ultimately, we're trying to see how can these AI-enabled tools help health systems get essential commodities to people when and where they're needed, essentially the 6 rights. So I think today we're really excited to give an overview of the tools and the problems they try to address and share some of our lessons, but also really hear from you about what problems you might face if these tools sort of speak to issues you have as well, if there are other issues you have. And I know there's going to be a live demo as well, so that you can see how the tools work in practice. But please use the chat or QA throughout the session, because we're very eager to hear your questions and insights. And one of the things we've realized is, if we can all really learn from each other, we can all make sure that AI works across our countries and our continents in a way that it addresses problems we all share. So with that, thank you for taking the time to join us, and I will hand it back to Ken and the team for what looks to be a very exciting session. Thank you.
Thank you, Yasmin, for the wonderful introduction to the team. I just want to maybe take people through, do a quick round of introduction to the team. We have the panelists here, and I'll be able to introduce each of them. Then we go straight to the panel discussion, and we'll finalize it with a demo on the same. So with me, I have a number of guests that you can see, and they can each say hello to us. I'll start off with, I can see Timmy. Timmy, you are on. Can you confirm if you can hear me?
Yes, Danielson Kennedy. I'm finally on. It's been a journey to this call, and I'm really happy to be here. Thank you very much for the warm way you have kept the house. Thank you. It's back to you.
Thank you so much for that. So I'll take it over. So we have teams from Kenya, and with me, I'll start off with the InSupply team. So we have Johnson Anyona. Johnson Anyona works as a supply chain manager with InSupply Health. I can see Johnson. Johnson is a holder of Bachelor of Pharmacy. Together, he has a master's from all the way from Rwanda on the supply chain. And say hi to everyone, Johnson.
Greetings, everybody. Good morning, good afternoon, good evening. I'm excited for this session and happy to be part of the panelists.
Thank you so much. I'll be picking at random so that I give a mix. So we have Dr. Kevin Awere. Dr. Kevin Awere is the county pharmacist for Nakuru County. Dr. Awere, can you say hi to the team?
Yes, thank you very much, Danielson. Hello, everyone. My name is Kevin Hawere from Nakuru County, Kenya, where I work as a county pharmacist. Looking forward to the discussion. Thank you.
Thank you so much. And then I have Dr. Lindsay Olima, all the way from Kakamega County. Dr. Olima, please say hi.
Thank you, Ken, and greetings all. My name is Lindsay Olima, Deputy County Pharmacist, Kakamega, and I'm looking forward to the discussions that we'll have through this evening. Thank you.
I'll come back to Kinyanjui Daniel, who is part of our team and our co-host. And then I have Bernice. You can just say hi as I welcome, last but not least, Dr. Wesaya. Bernice and Kinyanjui, they are doing the great work behind the scenes.
Hi, Ken. This is Charity holding fort for Kinyanjui. Nice to be here. Thank you.
Thank you so much. And lastly, Dr. Wesaya, David from our county pharmacist from Trans Nzoia County in Kenya.
Hi, everyone. I'm Wesaya David, County Pharmacist from Trans Nzoia, Kenya. I look forward to the discussions of the day.
Thank you so much. So maybe to the housekeeping issues a bit, just a moment. Okay, to the housekeeping, that is part of housekeeping that is happening here. To the housekeeping issues, so we welcome you to this webinar. Today we'll be having a session whereby we'll start off with a panel discussion. In the panel, we'll take 20 minutes for the panel where we'll be looking at the challenges and the pain points for the forecasting. And then that will be having the panelists, Dr. Were, Dr. Nyona, Dr. Lima, and Dr. Wesaya. And then we'll be able to give you a small teaser of, we'll take note that this is not a full training on a demo of the forecasting tools that we have. And lastly, then we'll just have a Q&A session, which we'll be able to lead. Now, you'll make use of the Q&A questions. You can leave your questions there. Panelists will be able to answer them as we move along. At the same time, you'll be able to put in comments, and we'll also be able to provide you with part of our contacts in case you want to follow up on anything. Is there any other thing that you'd want to know? Please feel free to raise up your hand if you have something burning, but we really want us to use the question and answer section. So thank you. Is there someone with further housekeeping, Yasmin or Timmy, before I go straight to the panel?
Thank you, Dr. Danielson. I really do not have so much of housekeeping than to say that I'm very excited that this is coming in at this time. Like the CEO of the in-supply team had rightfully put it, this is coming at a very right time. And I'm very excited, like I can see that everybody on this call is already very excited, given the conversation that we have had on the listserv, to delve into this conversation and see how we can resiliently forecast, quantify, and most importantly, allocate resources. So I'm excited, and on behalf of everyone here, I just want to say thank you ahead of time. And it's back to you, Daniel.
Thank you so much. So to go straight, I'd welcome once again the panelists for today. Once again, we have Dr. Were from Nakuru, Dr. Nyona, Dr. Lima, and Dr. Wesaya. And we'll just want for them to start us off by giving us just a background on the pain points that we've been having, that we have currently. And maybe just to go straight to the questions, is there someone, before I move to the questions, who has something burning? I assume none. I'm using two screens, so
No questions, Ken. I think you can proceed.
Thank you so much. So maybe to the panelists, to start us off, could you please, maybe I can start from Dr. to Dr. Wesaya and Dr. Awere, and I'm starting from the county perspective and Dr. Lima. So I'll start, any of you we can start with Dr. Wesaya. At the county level, what are your biggest forecasting challenges that you face in the day-to-day as you move along in the county? Which are some of your greatest forecasting challenges that you experience? So Dr. Wesaya, you can start us off, then we go to Dr. Lima, and finally Dr. Were.
Thank you, Daniel. I'm grateful to be part of today's discussion as a panelist, and I will begin by saying the greatest challenge we have had with forecasting is the accuracy of data that informs the final outputs of the forecasting exercise. This because most of our facilities, that is the health facilities, majorly depend on manual inventory, that is the use of bin cards and stock control cards that are manual, and any missed data, therefore, or erroneously entered data misinforms the final outputs of the forecast that you generate. Thank you.
Thank you so much for that. Maybe any addition, Dr. Lima?
Okay, greetings all. And mine is just to add that the challenge that we are facing in Kakamega is where you look at the allocations versus the forecasted amount. The gap that we have is still huge, and that shows that we need a lot of lobbying, because the way the health care system in Kenya is that health is devolved. So we have governors, and we have the county assemblies that we need to lobby with, so that we can have our allocations to the HPTs increased. So that has been our challenge, the gap between forecasted budgets and the allocated budget for HPTs. Yeah.
And thank you. I'll be getting back to you, maybe to push you further to give us more depth into them. But Dr. Were, from Nakuru County, and based on your experience as a county pharmacist, which are some of your greatest pain points and challenges that you are experiencing around forecasting?
Thank you very much, Ken. For Nakuru County, being also a county government, we more or less share those challenges that have been highlighted from both Trans-Nzoia and Kakamega. But in addition to the accuracy of the data that we have, and of those of what we use now to actually budget and plan, the process of forecasting itself in the past has been a very big challenge, especially when it comes to getting that data to start with. In the past, we have used a very manual method where we have been forced to go around getting this data from stock control cards, because again, our systems, our inventory management systems are largely manual. And then beyond getting that data, the other problem has been having that data be of the right quality that we have, which means that there's a process that has to be undertaken before we do the analysis. That also used to be manual. We used to identify the outliers in that data manually. Then we try to adjust. All that took a lot of time. So, and then beyond that, once we do the analysis, the other biggest problem we have, because obviously we cannot visit all the facilities, all the health facilities, is now to extrapolate that data to the other health facilities. I think that's it for us from Nakuru County. Back to you, Ken.
Thank you so much. And maybe Johnson, as you try to, based on the work that we've, and I also acknowledge the fact that you're a former sub-county pharmacist all the way in Nyamira. So based on that and based on the work that you are doing at InSupply Health, maybe could you be able to highlight any other additional challenges that you've been able to see, and even based on the work that you do at the national level?
Thank you. Thank you very much, Ken. Yeah, so I have been supporting the National Family Planning Program in their quantification. So I think I'll share that perspective on some of the challenges for this particular vertical program that might also apply to what other vertical programs are faced with. I think the issue of data, it used to be a challenge in terms of completeness of the data and reporting earlier on, but there's been quite a number of efforts deployed by the national county governments to enhance this completeness or reporting, as you would call it. Majorly, the program has really tried to tie reporting with resupply so that if you don't report, then you don't get resupplied with commodity. That has really contributed to solving that challenge that was faced earlier on the completeness. So the problem that we are still grappling with is on the quality of the data, as is the case with the county side. And I think with this, there's also been some interventions to try and validate the data, triangulate with what we are seeing in terms of the service uptake. Also, data review meetings. There have been quite a number of data review meetings to sort of audit the quality of the data and provide feedback to the generators of this data, and also get their understanding that this data drives in very critical decisions in terms of the procurement and resupply for the facilities. I think the other gap is on capacity. I must acknowledge that forecasting is one of the technical areas of supply chain generally. And so we've, as a country, we've heavily been relying on partners or in some instances, consultants to just provide technical input on this. So a number of trainings have been done, but you still find we don't have that richness in expertise to be able to steer the quantification exercises. We've also, in the past, been relying heavily on Excel, on the Excel-based tools, which, as many of you are familiar, not very many people are comfortable, confident in using Excel. And Excel itself has some limitations in that it's a bit manual in the nature of generating the forecasts. It is error prone. If you make a small mistake in the formulas, it can really distort your data. So I think those are some of the key challenges we've been grappling with for the family planning program that I have been supporting. Back to you, Ken.
And thank you, Johnson, for that. And I'm really curious on, you've mentioned around the data quality issues and the fact some of the tools which were used before. I'd want us to dig deep, and I'll get back to you, Dr. Awere, because you mentioned this. You talked about the manual tools that we have. And with the manual tools that you have, maybe you can speak more about them. And with that in mind, if there are any specific data gaps that you have that have most affected the accuracy of the forecast that you've had previously, and how you've been able to handle such situations whereby data is either incomplete or inconsistent. So maybe just taking you back to that particular bit.
Yeah, so thank you, Ken. So with the manual inventory system that we have, Basically, we rely on stock control cards to track items that we receive and issue out. And this is very much human-centered, which means that it heavily relies upon whoever is doing the transaction, either of receiving or issuing items, to first of all know how to fill the stock control card, and number two, to remember to do it at the point when they're carrying out the transaction. Now, the other problem that we have, and we have seen this, is that with the human resource we have, which is not enough, you find that in some of the health facilities, the health facility is being manned by one staff. Most times, a nurse who is the clinician, who is still the nurse, has to carry out the duties of a pharmacist, and so on and so forth. So with all these obligations that they have, sometimes they tend to forget to fill some of these transactions. And that now means that over time, the consumption data that you can be able to extract from the stock control cards is not as accurate as we would like to have. The other thing with the manual methods or the manual system of having the stock control card is that in a very busy health facility with many staff, sometimes those cards can get misplaced. And when they do, they get lost with all the data that is there. So we have had occasions of having that kind of breakage in terms of the history of transaction. Now, this presents a very big challenge during the forecasting process, because you are largely extracting the consumption data from those cards. And in those instances, now we have been forced to rely on the expertise and the memory of the person who is at that facility level to give a rough estimate as to what their consumption might be or is for a certain item. Or in cases where this has not been possible, then we use proxy consumption from a facility, most times within the same locality, and also with the same kind of workload. Back to you.
Thank you so much, Dr. Were, for that. And Dr. Wesaya, maybe you can weigh into the issues around data quality, especially on how then you go about it. So we recognize, as Dr. Were has mentioned about the manual stock control cards, we have few healthcare workers who are expected to play multiple roles, including filling in the bin cards, dispensing, among other roles. And at the end of the day, they have to do the reporting. And then now talking about the manual, which are some of the ways that you've used in Trans Nzoia to address some of the data quality issues that come about when you are preparing for the work around forecasting?
Yes, Danielson, there are some items that are specific for a given service, and just at a glance, you can easily pick out and see the data as reported in terms of consumption may not mirror the work load, and in this case, so often we tend to use the service data as opposed to the records of consumption that may be provided at that time. Casing example is the case of a product like chlorhexidine gel for cord care, which we obviously know it is one piece per live birth. And if you go to a facility, maybe you get reported consumption from the records is
300 for that month, say, yet you know the number of deliveries the facility makes is quite low compared to that figure, and then obviously it is not a figure to pick for your forecasting data. Sometimes in our locality, of course, operating within limited resources, there is a lot of task shifting. And so often someone may not pay very close interest to what is not directly within their training, of lack of interest for that particular. Can you hear me?
Yes, you are back. Please continue.
Thank you. So I was saying, because of task shifting in our resource limited setup, sometimes we end up assigning some duties, particularly relating maybe to commodity management and therefore inventory commodities they utilize. And because of that, relating to knowledge gap, they may not give you the correct data as you may expect. So
Thank
going
you.
forward, like I've mentioned, the aspect of utility service data is one. Like what Dr. Awere has mentioned, the utilization of proxy estimates using a near service volume facility with presumed accurate data is another option. Thank you.
Thank you so much. And I'll move to one thing that Dr. Olema had mentioned so that I try to move a bit faster. Dr. Olema, when you are speaking, you talked about some cases where we have the forecasts are technically sound, but resources or the budgets do not align. Maybe speak more about that because you mentioned it in your opening remarks.
Okay, I went and I talked of the outcome of the forecasting, which is usually the forecasted budgets and maybe quantities of commodities. So the challenge that we are having in Kakamega is bridging that gap between the actual county allocation on HPTs and the forecasted amount. So you find, like in our case, we have a gap of close to maybe $1 billion. So sometimes you try and look for ways to bridge that gap, because you know that there is need for that $1 billion that the county hasn't allocated any amounts towards. So you will have to be creative. Like in our case in Kakamega, we have decided to bridge the gap using the facility improvement funds. They have been consistent for some time. So with the reimbursements from SHA, that is the Social Health Authority in Kenya. We came up with a directive as the county health management team that 30% of that allocation, the reimbursements that facility gets through FIF is supposed to be put aside for HPTs. So we found that like in the last financial year, the gap reduced to from the 1 billion that we had to around 500 million. So that's one of the ways that we've been using. And we are not just seated, we are trying to lobby through our county executive, that is the CEC and the chief officer, to the cabinet and also to the county assembly, so that they can increase their allocations for HPTs. And we are hopeful that in this upcoming supplementary one, there'll be some adjustment, because we were promised, because if you look at our budget, it reduced from last year to this year. So we are hoping that in the supplementary budget, it will try to bridge the gap, and again, the facilities will continue procuring more HPTs and also bridge that gap that we already have. Yeah, thank you.
Thank you so much for that, Dr. Lima. And maybe so that the team are really waiting for some demos live and seeing what we've done so far. So from a tool perspective, from a support perspective, if you think about this is going to Dr. Awere, then I'll give Johnson again some few minutes to maybe speak about some of these. What support do you think would make the biggest difference for you in forecasting? Maybe just a few words on the same. In terms of support, think about tools, think about capacity, think about the data systems. So what do you think would make the biggest difference to you?
Yeah, thank you very much, Ken. I think for me and for Nakuru County in general, the accuracy of any forecasting event is very, very key. Because it has ramifications in terms of budgeting, it has ramifications in terms of the actual planning that we do. So for me, any sort of help that would reduce that margin of error while we are doing the forecasting will be a very, very great help. And the second thing, which I think I also mentioned earlier, was in terms of the capacity to actually do a forecast. Not all of our members of staff have that technical know-how of doing a forecasting and quantification. So again, support around that area just to make sure that everyone is up to speed in terms of knowledge will also be a game changer for us in Nakuru County. Thank you, Ken, and back to you.
Thank you so much. Johnson, something that you'd want to speak on the same topic in terms of what support you've been supporting the national quantification, county quantification from a support perspective.
Yeah. So I think for me, top of mind or top of priority is the what next after doing your forecasting. I think the team has really been doing a fantastic job in generating very high quality forecasts. We've recently done some analysis to just look at how accurate these forecasts are, and it is largely good to great. But now, once you do the forecast, the main point of doing a quantification is to inform financing decisions and ultimately guide procurement decisions at the stage of supply planning. So I think that's where we've sort of dropped the ball in terms of the follow through to use these results, especially since quantification is largely done by technical people. And the people who hold the purse strings are non-technical people. So sort of packaging this information in a way that is compelling and is able to guide the allocation, the release, the absorption of the funds to be used for procurement of these commodities. Then there is now the sort of aligning also. I think we usually, and I've seen this more recently following the withdrawal of USAID, is like whenever support is available, that's when quantification exercise happens. So in terms of the scheduling, I think it really needs to be well aligned with the budgeting cycle so that the results of the forecast are ready to serve as inputs into the budgeting process by the government, and it informs the allocation for procurement. On the tools, maybe just to add quickly, I think there's been, just to also give credit, there's been a lot of work done over the years. I think we previously used to use Pipeline and Reality Check, but now we have QAT that is really advanced, solving so many of the problems. But I think there's still room to even enhance it further to take care of the extraction, cleaning it that we still are doing manually. So I think those two, I think, are the areas that would really make a difference in advancing our quantification work. Thank you.
Thank you so much, panelists. I know I will give you, as we are continuing, I'll give you time to just look at some of the questions that are coming to the team so that one can respond to them. But allow me to thank you so much. I really appreciate. I will get back to you by giving you one round just to give us your final thoughts on the same. At this time, I would want us to break and just give you a teaser of some of the things that we've done to try and see that we've gone through the quantification process. So I'll start with the easier one. So George, I don't know if you're ready with the county quantification tool, so that we can start with George to take us through the county quantification tool, and then I'll be able to take you through the family planning quantification tool. I'm trying to share my screen. Post, please. Okay, I've now been allowed. So I think because of that, I'll just go ahead. Confirm that you can see my screen.
Yes, Ken.
Yes, we can
Okay.
see your screen.
Okay, so
Dr. Kennedy.
Yes.
if I may, I want to join you to say thank you to all of the panelists. While the conversation was going on, I also peeked into the Q&A session, and there was a comment there. So I want to call your attention to that. Do you want to take that now or take that after the demo? The comment is more like providing light from another country's perspective. So I want to draw your attention to it, and you can take the call.
Thank you for that. I think we can quickly take the question. Now that I've shared my screen, I don't have much control on some parts. So Johnson, do you mind please taking up that?
Sure, let me just read it out. This is a comment from Jimmy Aiden. Perspective from Nigeria. Aside the data quality issues, access to advanced tool for quantification is a challenge at the sub-national level, where access and capacity to use tools such as QAT, Quantimed, and Pipeline is limited. At the subnational level, states have to use a developed tools on Excel, which has limited capability in terms of advanced statistical models to provide better predictable models. The integration of AI on locally available tools developed on Excel will be a game changer, especially in the context of funding challenges from international donors and support. Thank you very much, Jimmy. I totally agree with your comments. Just to weigh in also on that, we actually did a supply chain assessment in Nigeria earlier in the year. And yes, we were able to appreciate the efforts that the federal ministry is in collaboration with the states in terms of decentralizing and devolving some of these functions. And one of the key findings is that not a number of the states had their own state-specific quantification outputs, as you've pointed out. And I think, yeah, you have to start somewhere, at least starting the exercise so that you give the system time to mature to the level of integrating the advanced tools. So I think just acknowledging the states that have really made efforts to do their own state level quantification exercise. Thank you. Ken, back to you.
Thank you so much. So I'll do a quick demo. I'll start with the easy one as I bring George, you prepare for the next one. So in the interest of time. So we have, we'll try to do at least 3 quick demos. So 2 in Kenya and 1 in Tanzania. And the way we've chosen the approaches is such that we are able to give you how do we go about a national forecast, one that uses vertical, a vertical program. And I'll take the example of the Kenya family planning, and then we'll go to the county quantification, which looks at the subnational, the commodities that are looked at being managed at within the facilities, but are procured from the counties themselves, the essential medicines. That is the national tool. And I'll give the case example of Nakuru County. George will be able to take us through that. and then I'll be able to give the bottom-up quantification example that I'll be able to welcome my colleague from TZ, or I'll pick it up quickly. So in Kenya, what we've been able to do, so one, we've been able to integrate the data that is coming from the KHIS with working with the national team. So we were really part and parcel of the quantification process. You had Johnson mention about the Excel, using the Excel methods to do the quantification. At one point, we had the privilege of doing the quantification using the QAT. It still had some limitations. And this part of the work that we've done a number of work, even in the maternal child health. And to really answer part of the questions is that whatever I'm demonstrating here, if you have used, if in your country you have like DHIS, it will take a very short time to do the same. So we have integrated the data that is coming from the DHIS2 instance, which in Kenya we call the KHIS, and there is data that is already preloaded into the tool. So the first part is you look at the trend analysis, where you are looking at how is the data showing between the service data and the consumption data, so that you are able, one is able to clearly identify is the data coherent between what is being reported in service data and consumption, and how does it look like. So for example, I'm just picking EC pills, I can pick the female condom, I can pick any of the family planning methods like the COCs. So you're able to see how, I think these are a good one that you can see, just comparing between what is demonstrated between the red one is the consumption data, and the black one is the, I hope it's black, is the service data. Then we go at looking at the quality of the data. So we do what we call the anomaly detection, identify whether there is the data which we have having some challenges in it, yes or no. So in the anomaly detection, one is able to identify, just the model is able to try and see inherently, do we have data quality issues within the data as it currently is, which we are able to narrow down. Like here, you can see there is a quite, in that particular case, you are able to see that the way the data was at this stage, there is there was something that is extraordinary. It's so either very high or low. And then I can pick that for another commodity. I'm just picking at random so that I see the running of the anomaly. So you are able to see that based on how the consumption is going on, or the services that are being reported, so changing from one to another, yes. So you can see here consumption, this is a good example. So this is the real data for EC pills. You can see that where our consumptions have been, it was going at almost 11,000 per month. And then there is this particular month that is 71,000. And you can see that that is a huge increment in that particular month. So the tool is able to quickly identify where the problem is and be able to do a correction of the same, do data cleaning of the same. So the first part is you able to inspect, do the anomaly handling, do the corrections. And finally, what it's able to do, it's able to run for you the forecasts for the different commodities that you are looking at. So you are able to see that this is how the data for COC is looking like. And then this is the forecast, how it's going around, whether this is the service prediction and the other one is the consumption prediction, how it predicts it for you. I'll be able to mention then we have several models that have been applied at the back, and it will be able to pick for you for that particular commodity, which one has got the least error. It happens that the two that I've picked is using the same model. So let me try a different one. Yes. So I can see that here for the consumption, it has picked the random forest as the model, the best model. If I pick on the male condom, you can see there is the Prophet model for, and then there is a RIMA model based on that. So this is what it's able to do. We can always do live modeling where we are able to quickly make some decisions, like I'd want to look at the forecast horizon to be 36 months, just changing that. and try to see that, do we have seasonality, yes or no? And then I can do and say that, can it run for me the forecasts for service? And you can see that for two-rod, it's been able to give me the forecast, one, be able to show you the trend, what has been there, and then be able to give you a proposed forecast. It gives you the lower bound, the upper bound, and the point estimate. The same data, you are able to put it on a table which you can download and the teams use. Recently, we've added forecast accuracy, and the forecast accuracy basically looks at the actual data that we have and based on what was agreed upon as the forecast. And now when you come to the actual consumption as it's coming on the DHIS2, then how are we looking at our forecast accuracy? And we've been able to look at the different forecast accuracy methods. We can also do a live, you can, if you have logging into the DHIS2 in Kenya, you can put in your logging in credentials, username and password, and be able to log in. This has been integrated within the KHIS, download the data, do the data cleaning, just the normal way that we've gone through these. So that is a teaser. If you want to know more, if your country is using DHIS2, we'll say that we are able to customize this and put it for you. And the teams have been used this. In the last quantification that we had for the country Kenya, we managed to ensure that we, we say forecasting is both an art and a science. So after the science, the quantification team sits down and agree that which of the forecast makes more sense. And we are happy to report out of the 13 FP commodities, 8 out of them they used the AI, the output that came from this particular tool. So let me stop at that particular time and quickly welcome George to take us through a quick teaser on the same for the county tool.
Thank you, Ken. Would you love me to share my screen or?
Please share your screen if doable. It will be much easier for you.
Yes, thank you. My name is George Mwangi. I think I didn't introduce myself at the start, but I'm George Mwangi. I also work for InSupply Health. I'm part of the analytics team, and I'll be presenting some work we've been doing around forecasting of essential medicines at the county level. So this is some work that has been going on, trying to advance as we have come from like very basic steps now into where we are. Like from where I started, I don't know if you guys can see my screen. Please confirm for me.
Yes, now we can see your screen.
Yes.
All right. From where we started, the work was very tedious, erroneous, and full of, a lot of hard parts that needed the team to sit down, look at the data, make sure that we have everything put together, and then there's someone else to upload those files into another separate worksheet. And just to get to the results section, it was very tedious and very manual. So because this is mostly because for essential medicines, it's very large, like you're looking at a list of more than 2,500 commodities for the very large facilities. And for you to be able to quantify for all of those. And the unfortunate case here is that we don't have that data in an electronic system. So people had to go to the facilities, make sure that they collect that data, and now sit down together, look at it, verify that it's okay, and then try to make decisions around that. So we sort of started somewhere through a very mini application where we would ask people to just upload the file and it would do the hard bits. But now in the later stages that we have been involved in, the process needed to be scaled nationally so that we are not just supporting a few counties, but rather now the whole country. And this is what I'll be presenting this particular tool. Like the process allows for someone to log in at either a county level, national level, or either an administrator or something like that. And then they select the county. For county level users, you would sort of select, I've done some dummy data for Nakuru, and I know Dr. Awere is here, so it would be very good. And then once you log in, you are able to have some sort of planned stages that you are able to do within the tool. So one of the very thing we thought to have a standard way of people making sure that the data around quantification, like what we need to know about the forecast horizon, the buffer period, everything is sort of set in one place, and the team doing the data collection don't have to think about what those Excel sheets will have. So that's one of the steps that we had at that particular place. And then also, because for essential medicines, due to the large list of facilities, it would sometimes take a lot of resources to visit every facility in the country to collect data. So we sort of had a sampling way of doing the data collection, such that you are looking at a few facilities and then use the data from those few facilities to extrapolate for the others in the county. And that was another very hard process, because initially it needed the team to sit down, link different worksheets full of very many sheets, and then try to come up with the results at a county level. So we standardized that process such that to get the template to classify facilities, it would just be simple from the initiated quantification plan. People would just select the facilities, and the tool would sort of propose. If you look at this particular sheet that I have opened, it's just a very, let me just zoom in. Looking at the facilities in Nakuru County, it sort of sorts them by level and sub-county, and based on workload, it's able to propose likely classification. In this case, we only have 3 classes: low volume, medium volume, and high volume. And then automatically it samples the one with the highest workload. But this does not mean the team is fixed to choose that. And then they're able to validate this. I mean, it just gives them a certain point. And from there, they can be able to upload that back in the system, which they'll be able to see at this particular step. They also look at the product list, which is still within the system. Everything is sort of standardized. And when it comes to the data collection step, they also get the tools from within the same system and upload them back there, which is sort of, we found that is a more scalable way, other than people having to manage the metadata about facilities, like what you need to know about the facilities, so that you can link those different workbooks and all that. And then when the team is like 100% complete at the data collection step, this tool behind the scene, it automatically extrapolates the data from the sampled facility to the non-sampled, so that they don't have to go through that hard work, and it sort of saves a lot of time to do that. And then now looking at the other step, which is mostly the result section, the team is able to look at what has been uploaded, and this is available in real time as the teams upload where they have gone to collect data. So someone somewhere can be looking at this, manage progress, and they're able to see this is just some dummy data, it's not correct. They're able to see, like, for different sub-counties in the county, how is the requirements, by sub-county, by level of care, by just showing this sort of interactive dashboard, and then by product category, and also based on the funding source, either from the county or the national strategic programs. And that data is also available by looking at ahead, like year 2 in year 3, because sometimes they say we want a report for the next 3 financial years, and all that is available in the same tool. So we are sort of providing analytics on top of what was collected in the facilities. Yeah, and that's just a teaser. The tool also provides sort of an overview of what is within the system. So if you have something you're not sure about, you just come here, and it sort of have a simple documentation where the team can refer to. And that's just it. I would have loved to maybe take the team through the extrapolation process, but this just a quick look at it, how it happened, looping over all the sub-counties and the classification, either high volume, low volume, and middle volume, and so on and so on. But I would like to stop at that so that we have time for Q&A. Thank you so much, Ken. Back to you.
Thank you so much. And just as you're there, you can linger on the forecast results as I say these. So these are typical example of how we are using a scenario where we have manual methods, which Dr. Were was talking about. You have limited resources, so you can't go to all facilities to go and collect data. So data collection is done manually from the bin cards or the stock cards. And you're able to collect data up to maybe you define it either 3 months back, 6 months back, be able to put that data together and using a sampling approach for certain level 2 and 3 facilities, you'll sample and then you are able to make assumptions. And remember, forecast is a best guess. You are making a good guess of what is required. Again, Dr. Lima, when he was speaking, talked about 1 billion. So if you're not a Kenyan, you may be wondering what's 1 billion, so or 500,000. So you may find that when a country, based on the requirement, sometimes the gap is up to 50% financial gap based on what the requirement you need and what you have. So I don't know if I'd as bring back so that I move out of Kenya. Peter, if you are ready, you can just do again a very short demo of one of the Tanzania specific tools that we've done.
Sure. Let me just share my screen. Okay. You'll confirm if you can see my screen.
We can see your screen.
Positive, yes.
Thank you, thank you. So in Tanzania, we do our forecasting in using the previous year's data. We use a naive forecasting method where you combine all the consumptions from each facility for the whole year of last year, and they give it to them as a suggestion, as in, this is what you're going to be using this year. And the users get they get the platform to be able to say, okay, this is, I'm going to use the same, or I'm not going to use the same. So in the tools that we use to report our consumption, we do an R&R, which is the request and requisition. So it's just a list of all the commodities, and we say how much we've used in each 2 months. They report by monthly. So one of the tools that we built was to take a tool that would parse this PDF, that is a report from the R&R, and just to validate it and just to make sure that what you're reporting makes sense. So we had to make a tool that kind of accepts a PDF and not an Excel. Let me just that would accept a PDF and just parse your whole file, and you can process it. So instead of that whole sheet, that's just a PDF, and you cannot see actual analytics of it. They would have to come here, upload it, and they would process it. And then it would then give them some insights about the data that they are about to submit as their consumption. There are some policies that they have to have priority items reported. So they have only, like this facility only reported 48 out of the 101. This kind of tells them, okay, go back to your report and do it right. It tells them the total inventory costs and other stock on hand distribution, whether they are overstocked on some items or understocked. So that's our role in making sure what they report as consumption is correct, so that the forecast can make sense. So when we go to the forecast part, we use what we call ELMIS, which is based off of a backend called OpenLMIS. And the user would go to create their forecasting. So what they would see is, let's just wait wait for it to load. And here the great part is we've been able to integrate this with the government system. So what you're seeing here is a training instance. I don't want to mess up with the data from the actual website. So you'd see the adjusted consumption for the whole last year, and then you'd see the forecast demand. This is what they can change. So that you've been told you've used only 2 last year, you can change it to 5 this year. And then you'd have to put a remark, I put 5 because I'm expanding services. Where do we come in? What we do is this little button here where you see validate, that's where we were able to put in our tool that validates everything that they've done in this sheet, their forecasting. So when they click to validate, what they're going to see is something similar like what we saw in the R&R, but it's a summary for all their forecasts. If you look at it from a perspective of just a sheet, like what you're seeing here, it's hard to see the numbers. It's hard to see the trends. But once you say validate, let's just give it a minute. And I hope I'm not taking too much of the time. Yes. So this is what you'd see if you validate. It will tell them, okay, you've done your forecasts, but you have 8 duplicate products. What does that mean? It means that there's some products that you forecasted for 2 times. So the government had this problem where a facility would ask for the same product twice. This would really mess up with the numbers. They would think that the facility needs 200, well, it only needed 100. And they would be able to dig deep and see what actual products they are, and they can go back and clean it up back on the actual platform. That is just one of them. They can also check out the priority items. This we saw in the R&R. Like every service level needs to have a specific number of tracer items that they need to forecast for. And they can see which ones are missing. Like this one is being told antitoxin and urine specimen collection containers. You have not forecasted for them. So it's just parses through all the data and gives them a short summary, an actionable summary that will help them to make better forecasts and reduce the number of rejections or validations that needs to be done on each level, from the facility to council to region to national. One important chart that they have to review is one that checks out like outliers. So like if your last year you used only 3, and then you've said you need 10 this year, it's going to highlight it. If you say if it's going to be maybe 2 times of what you had ordered, maybe a power of 10, it's going to highlight it, and a user can even like filter out, okay, which ones has a ratio greater than 2 in terms of comparing what you used last year and this year, just to make sure that what I'm ordering makes sense. So these were all like co-created with the government, what they wanted to see, what they wanted the facilities to pay attention to. And that's how we came up upon building these dashboards. Thank you. I think I've covered enough. Back to you, Ken.
Thank you so much. And I think that was a variety of giving each and every person. I think there is one that I'd maybe, I don't want to share it as work, but I'll mention it because it should be part of the things that we may present for you next time if we had time. You remember Dr. Lima talked about they have less money. Your quantification is this 1 billion. The need is 1 billion, and you've only been allocated 500,000 or 500,000. So how do you go about it? So the tool that I'll not speak about, there are so many of them that we've developed, is one that gives you ability that if you have 500,000, I'm just using that as an example. So if you have, sorry, okay.
Okay, and then you'll come for me.
Okay. Sorry about that. That's part of working at night. Sorry about that. So if we have 500,000, so you simply say, what is this 500,000 to be used for? Is it to be used for dental, for whichever areas that you want to use, for which level of facilities? Is it for all facilities? If I remove maybe level 5, we say this money is just to be used for 2 levels of facilities. And then how do I divide it within the level 2 facilities? Initially, Dr. Awere will tell you there are some challenges that they've had and so forth. So this tool, without taking so much of your time, helps you to allocate the money to the different facilities. And once it has helped you allocate the money, it will also help you to, once you know maybe one facility, this is like they have not been given this much, how do you, oh sorry, I think I put so little, but if you have whichever money that you've been given, it will help you to know which commodities now to procure. So with that, allow me to stop there and maybe welcome the teams. Maybe just if we have quick questions which we've not been responded to, and if there are any, then I take back, after the question, take back to the panelists for any final thoughts, and then we'll be able to take it back to you. So are there questions? One of the common questions is, where are the tools hosted? Are they, how much do you pay for them? So just to let you know, all our tools that we've done, number one, we've tried as much as possible to integrate within the national systems so that they should be able to work. So there are those ones which we are currently hosting, which we are in the process of transitioning to the government. There are those ones which are already transitioned fully to the governments. And then the second part, we use open source tools without requiring that once we've left, then the governments will need to pay some money. And last but not least, we work hand in hand, we co-create with the governments, just to let you know. So are there burning questions?
Thank you very much. Thank you very much, Kennedy, and the entire team. Thank you, Peter, George, Dr. Olima, Dr. Awerse, Dr. Johnson. I really want to appreciate you. There seems to be a couple of comments that we have started responding to, both on the question and answer section and the chat boards. Someone had asked or had written something like, "Thanks team for the presentation in addressing this important pillar of health using AI-driven tools. Have you managed to go beyond procurement and calculate the forecast accuracy in any region or county or country?" And Johnson had responded in a way, but I just wanted to confirm from the person who asked the question, has this been addressed? Do you want to speak to it? If you want to speak to it, you can just raise your hand and then the host will give you right to speak. And if there are other persons who may have burning questions, it is time for us to raise our hands and then attempt to give you right to speak. And then on the chat box, I see a lot of interaction. There are different perspective from their perspective from Nigeria, and then around the difficulties and some strategies that had been developed to enhance this process. All of these have been interacted around on the chat box. There are responses from different persons about where this can be used. So I just want to say at this time, it's important for us to lend in our voices. If there are anyone who has something to say, either a question, a comment, requests for the tool. I can see Irvan from Pakistan had already requested for the tool. It's time for us to dive into the conversation with questions, comments, and potential requests. Do I have anybody who wants to speak? Jimmy, do you want to speak to the comment you made earlier? If you like to speak, you just indicate, okay. Can somebody grant Jimmy access to speak?
All right.
Venice, yes.
Am I
Great.
audible?
Yeah. Yes, we can hear you, Jimmy.
All right, great. Thank you. Thank you very much for the opportunity to join in and also contribute on this aspect. When I saw what is being presented in Kenya and Tanzania, I'm actually very impressed how we are using locally developed platforms to be able to inform our quantification and procurement decisions. This has become very imperative in the light of what is happening within the development space, where from the beginning of this year, we've been having a lot of funding disruption and challenges. And this locally developed tool is going to go a long way towards ensuring sustainability, such that even when those international donor support is no longer there, the government, whether at the national or subnational level, will be able to lead those efforts towards ensuring product availability to the last mile to advance better health outcomes for healthier population. Just like I started from the message I dropped in the Q&A session on our experiences from Nigeria, quantification at the national level for public health program has really advanced, where at the national level, we use quantification tools such as the quantification analytics tool. Previously, we used to use Quantimet for forecasting and pipeline for supply planning. But with the USAID developed through the quantification analytics tool, that has integrated those two systems into one, and then with advanced statistical model for better predictability. So that is good. So the only challenge we have is majorly at the subnational level, which are the state level. In Nigeria, when you're talking about the essential medicine, for instance, the responsibility lies much more with the state level, with the state government to be able to provide those essential medicines. And within those states, we have what we call the drug management agency. It's similar to what we have in Kenya, KEMSA, which is the drug management agency that provides health products centrally at the nationally, and then move them to the county. But in Nigeria, the difference is that that drug management agency, we have almost every state has that. So what that means is state has to lead the quantification of essential medicine. So as part of the organization I work with, we support some fewer states to be able to quantify for essential medicine at the state level. Our biggest challenge and pain point is access to advanced quantification tools to be able to improve the quantification accuracy. The challenge we have here is the quantification analytic tool is a program tool which the USAID has developed and being managed by Chemonic through the JHSC project. What that means is other partners, other programs do not have access to that tool to be able to use. And I'm happy to what is we've seen in Kenya and Tanzania. And I think the welcome development, we can leverage on their experience to be able to support those states to develop their own tools such that they will be able to use that. So I think that's the additional perspective I wanted to provide. So this is really helpful. The experience from Kenya and Tanzania, it has given me a huge relief that whatsoever we want to do at the subnational level, it's possible, integrating it with the existing structure. Thank you, and over.
Thank you very much, Jimmy, for providing that slide. Yes, thank you. And we have just about 20 minutes left. I just want to still leave out room for responses to the questions that have been answered already, just for us to have a a common understanding of what responses had been provided for individuals. Dr. Johnson, Kennedy, do we have anyone to just quickly share some light on the questions that have been asked and possibly answered on the Q&A?
Yeah, I think there was another question there on speaking to the focused accuracy work. So the advantage we have with the national programs is that the data is readily available to be able to do such analysis. So whenever you're doing focused accuracy, you need two main data sets, the forecast that you develop and then the actual consumption data. So for most vertical programs, both data are readily available, so you can easily do forecast accuracy, even with simple Excel spreadsheets or with the advanced analytics. And even as you saw in our AI tool, we've also incorporated that. But now for countries where, like the example of Kenya, in our devolved health system, the essential medicines don't really are not all reported on the health platform, on the HMIS or on our DHIS too. So as was mentioned earlier by other panelists, this data for actual consumption lives within the bin cards. So it becomes a lot more complicated for you to do forecast accuracy for such products where data isn't tracked or reported on the national platforms. But for in scenarios where you have both sets of data available, it's very easy to move ahead with doing such analysis. Then on the question on the sources of data, I just wanted to add some context that the responses I gave were specific to the examples that we've discussed today, but depending on the because someone had asked the source of data used for forecasting. So depending on what you are forecasting for, are you forecasting for lab commodities? Are you forecasting for a product which is integrated, a product which is vertical? It can give you it sort of can limit or give you the opportunities of types of data that you can use. But generally, for most vertical programs, the three types of data that I have shared, that is consumption, service, and demographic, are usually used to generate forecasts. Thank you.
Thank you, Dr. Johnson. Kennedy, do you have a thought that you want to share?
I think everything has been said, but I feel that I would do injustice if I don't mention the following. Part of the work that we've done has transformed what could be taking weeks, 3 weeks, 4 weeks, a month to do into doing it in minutes. Just letting you know, like the family planning quantification, integrating it with DHIS2, you are able to do from the data collection, cleaning it, and doing the forecast so that you are able to clear time. There are the issues around the accuracy that we've been able to, you are now more confident because you are doing the data cleaning, we'll be able to curate for where there are outliers, pick out them, because you know when there are inaccuracies or outliers within facility level, you can't do that among so many other things. So for me is that there is a lot of hope. We are proud that this is done locally. It can be contextualized to any other place, and we do the co-creation with the government so that we don't do things on the side and then come and tell them, oh, we have this new thing. So in terms of confidence, then people will be able to leverage it is acceptable because of the process that it has taken. Thank you.
Thank you very much. Thank you very much, Dr. Kennedy and the experts that have shared the demos with us, the experts that have shared the use case and the problem with us. At this time, we have very few minutes left. I'll just invite the communication team behind the scene to help us launch the poll. There's a poll that will come up that we will request every one of us present here to respond to so that it can guide us on how to move us to the next level. While we're at that, I just want to share with us, the poll is on now. I will encourage us to have it done within the next 2 minutes. While we are doing that, I just want to share a little more light on what we are doing. you will realize that we have started the moderated discussion on the IAPHL listserv, and a lot of us had jumped into the conversation. We had shared our thoughts, we had asked questions, and that is what the moderated discussion is for. What we noticed from the moderated discussion is that we wanted more around unpacking the problems around forecasting, quantification, before we eventually get into what our initial ambitions had been around sharing with you some resource mobilization and resource management tools. So that's why we had taken a detour, sort of, to really expound on what the problem is. And instead of having just one webinar, we will be having a series of webinars. Now we had unpacked the problems. The conversation we expect to continue on the listserv, even on LinkedIn. Expect you to continue the conversation, whether in the course of doing your work, something comes up and you quickly want to ask or add to what the conversation is. You go ahead and do that, and then we will converge again for another series where we will take a deeper dive into the tools that we had used and see how it solves individual or specific problems, and we can now put it in context across geographies. Again, I want to say thank you to everyone. Our time is fast spent. Please quickly respond to the poll. But while we are still doing that, I want to quickly give the opportunity for 30 seconds. 30 second last word from our experts and panelists. I want to start from Kennedy. Kennedy, what will be your last word for now in 30 seconds?
We are tried and tested. We are here for you.
Fantastic. Dr. Olima, what will be your last word for now? Do we still have Dr. Olima there? Okay, if we don't have Dr. Olima, can we have Dr. Johnson? Dr. Johnson, what will be your last word? Okay, go ahead.
Yeah, yes. So I think just to echo what one of the Jimmy from Nigeria had talked about, it's now the time for homegrown solutions. And so there's plenty of opportunity to leverage on advanced technology to enhance our quantification, make use of smarter tools, get our data to be of better quality, and to strengthen the capacity of the quantification teams. Thank you.
Thank you, Dr. Johnson. Dr. Awere, can I have you? 30 seconds.
Yes, thank you, Timmy. Thank you, everyone in the meeting. For me, I think the issues that we face, not only in Kenya, but in Africa, especially in regard to health, have been widely summarized into two. One is insufficient resources, and the other one is inefficient use of the little resources that we have. So any opportunity that we get to leverage on technology to sort out these two major problems should not only be embraced, but also be very highly encouraged. Thank you, and back to you, Timmy.
Fantastic. Thank you very much, Dr. Awere. Dr. Wisaya, can we have just a quick one from you?
Yes, just joining with what Danielson mentioned, this is a tool which was tested or piloted within my county, and I can vote for it anytime. Thank you.
Thank you. Thank you very much. That's about it. We are right on time, and we want to say thank you to every one of us. Like I said earlier, the conversation continues on the listserv, on LinkedIn, and you can reach out to me, you can reach out to Johnson and any of the experts directly, either on LinkedIn or anywhere. You can also reach out to InSupply for us to have this conversation enhanced. The idea is that this homegrown tool should be adopted and used to enhance what we love to do, making products available, life-saving products available wherever it is needed. So on this note, I want to, on behalf of the team at InSupply and the team at International Association for Public Health Logisticians, want to say thank you for your attention, for your time, for your contribution. It's over now for now, but the conversation continues until we get the product to everyone who needs it. Thank you all.
Bye, everyone.
Thank you so much. Bye.
Thank you.
Bye.
Bye. Yes, you can unmute and just say bye to your friend, and then we call it a
Thank you.